Good afternoon, everyone, and welcome back to Track 1, Care and Support for Kids, sponsored by Horizon Pharma. Thanks to Pfizer for sponsoring this afternoon's lunch. My name's Christian, and I will be the track host for this final session. As a reminder, I'd like to welcome those of you joining remotely through the live stream, and remember to download our app to use some of our highlighted features like the live QA. I'll be asking some of those questions for you guys during or at the end of our presentation. For this session, we will be holding all of the questions until the end. For this last session, Experiencing Transitions in Care in Life, we are joined by two great speakers. Simi Trachtenberg, Director of Community Education at the Children's Hospital of Philadelphia, and Mary Zupance, Division Chief of Pediatric Neurology at the Children's Hospital of Orange County. Let's give them both a very warm welcome.
So good afternoon. Hopefully we won't put you to sleep after lunch. Transitioning care from the pediatric world to the adult world is challenging not only for us as providers, but for parents and for the children, young adults themselves. And as a result, Simi and I have had the opportunity to be part of a national task force, transition committee task force, organized by the Child Neurology Foundation in coordination with the American Academy of Pediatrics, the American Academy of Neurology, and Child Neurology Society, many other advocacy groups. And on that committee, I'm a physician, there were social workers. Simi is just the quintessential social worker, in my opinion, who knows a lot about transition, but parent representatives, some advocacy groups, occupational therapists, physical therapists, family practitioners, pediatricians. So we tried to make it a diverse group so that we could get input from everyone. To help Simi and I this afternoon, it would be really helpful for us to know our audience. How many of you are healthcare providers, whether it be nurses, nurse practitioners, physicians? So not very many. Okay, that's helpful. How many are parents or care providers? How many are children, young adults with special needs? Okay, good. And some have demurred and decided not to declare. But that gives me that my focus is going to be a little more medical, but I'm going to provide some actual patients that I have transitioned to adult care and provide some examples of how complicated I found it to be and complex. And I've also struggled because many of these patients are patients I've followed for years. I received my MD degree from UCLA, but I spent most of my time in the Midwest at the University of Wisconsin, the Mayo Clinic, and the Medical College of Wisconsin. So I still see, and I spent some time at Columbia University, so I still see many of those patients. They come to see me in Orange County, which is wonderful because I have a few patients who I've followed for over 30 years. And I've gotten familiar with what some of the true challenges are with transitioning care, whether it be from one pediatric provider to another or from pediatrics to adults. So I'll go through a few cases and what we as healthcare providers see as challenges, but also to empower you as parents, healthcare providers, and young adults with special needs. Some of the questions that you may ask your own pediatric and adult care provider that will, I hope, empower you to ask the important questions. It is okay to ask your provider, have you ever taken care of a patient with my condition, for example? On what do you know about this particular syndrome? And many of the patients that I take care of, it's not just neurological, there is a multi-system disease, and so that presents even bigger challenges. So in the transition committee, I just want you to outline 8 principles that we came up with in our committee that we thought, because it's a transition process. It's not something that at 17 I say to my patients, oh, you're going to be 18 next week. Bye, so long, farewell. Here we are. I'm sending you off to your adult provider. It's a process. And we really think the initiation of the discussion should start right around the time of puberty, which in the United States is younger than 13 years of age, but it's, 11, 12, 13, to start the conversation, because it can be surprising to parents in the United States. You don't, as a parent, when your child turns 18, you are not the guardian of your child. If you have not gone through conservatorship and guardianship, that child young adult is considered an independent person. And with some of the young adults that I transition to adult care, they really need some help. It may be completely dependent on a guardian, or there may be varying degrees. And it has to go through a court of law and a judge. And so it's not something that just happens overnight. That takes about a year or 2. The assessment of self-management skills, and we do have some materials that Simi will go through on our website with the Child Neurology Foundation, and we have some in ours at the Children's Hospital of Orange County, but CHOP, Children's Hospital of Philadelphia, also has some tools. But our self-assessment tools on the Child Neurology Foundation website have been fully vetted and I think are really good to give the child, young adult, emerging adult, and the parent some idea of what the capabilities are of your child. And then phased in self-independence and management of care. It's always shocking to parents when, for example, the biggest risk of non-compliance of anti-epileptic medication, because I'm a child neurologist and my specialty is epilepsy, the biggest risk of non-compliance is the age of adolescence. So I just assume my patients it's hard to take medication anyway, but I just assume that my patients are not going to be totally compliant. And so when I see levels that fluctuate back and forth, they'll say, oh, it's because I'm growing. Or I didn't get a trough level, I got a peak level instead. And when we point out to them, I just put it on a graph and I show it in the exam room, they go, oh, maybe not. And as long as we all understand that there are going to be lapses, we can work toward increasing self-independence. And then a discussion, as I mentioned earlier, discussion and determination of the use expected legal competency. And that may fluctuate. So evaluating it every single year from the age of 13 gives you an idea of the variations. A discussion of a comprehensive healthcare plan. So, for example, I am often, as a pediatric neurologist, I'm not just their pediatric neurologist. Many of our pediatricians don't even want to see the children that I take care of. So if they have urinary tract infections or abdominal pain or vomiting or upper respiratory infections, the pediatrician usually says to the parent, oh, call your child neurologist. It must be related to the medications or their underlying neurological condition. So I've kept myself accredited as a pediatrician, and I must say I'm pretty good at it still. But when we're formulating a transition of care, I need to be in communication not only with the neurologist, but let's say if they have tuberous sclerosis complex that affects the kidneys or the heart or the lungs, I'm going to be in touch with not only the primary health care provider, but other pediatric and adult subspecialists. The identification of potential adult providers, that's our biggest challenge. It is across the country. Many of the pediatric diseases that I'm going to go through here today, our adult providers haven't even heard of them. They have really no idea what Dravet syndrome is. Or one of the more complex epilepsy syndromes like Lennox-Gastaut syndrome is different in pediatrics and changes over time and is unrecognizable to the adult provider. And it's very, very important that the adult providers become familiar with these disorders. And we do have a plan. And then when we transition, we want a written transition packet that outlines a concise but complete summary of the patient by system. So neurological, that would be written by me. primary health care needs, if there are GI issues, let's say the patient has a young adult has a gastrostomy tube because has difficulty swallowing, we want to make sure that we get a good adult neurologist. So a written transition packet, and in my neurological summary, I outline bullet points about what the child's epilepsy is and underlying neurological condition, maybe a brief summary of what that condition is, and then if they have difficult to control epilepsy, what drugs they've been on and what the side effects were and what has been the most effective combination, so that they have a synopsis of care. And then I don't just say, go forth and prosper and I'll see you later. The most important part of effective transition plan is really, we have the luxury at CHOC, and increasingly so because I've now identified an internal medicine specialist and an adult neurologist who will come to our clinic and meet the family and the young adult prior to transition. And then we will make follow-up phone calls to make sure that the next subsequent visits have gone well. And if they haven't, we'll have a conversation. And I also provide every single adult provider with my personal cell phone number and a number to our office, so that if there are questions, they have a resource. So they're not just, the adult provider can be a little bit anxious. So I think that's important. And here's the reference to the article that we've written about transition. It was published in Neurology, which is the official Green Journal of Neurology, the neurologist's role in supporting transition to adult care. But it really, the transition committee really encompasses transitioning any child, young adult with special needs to adult care. So I'll go through a few cases, and I won't belabor the point, but it's just to give you an idea of some of the range or the scope of young adults that we all take care of as healthcare providers. And you may recognize yourself in there if you're a young adult with special needs, and parents, you may recognize some of your children in this. But this is a complicated one in the sense that it's a 16-year-old adolescent girl, good verbal skills, maybe a little socially awkward, but making good progress in school, and has really struggled with her autistic features, but is really quite engaging. Her IQ is what I call on the borderline range, so she has some challenges. The average IQ in the world is between 90 and 110, so 75 borders on being some cognitive limitations, which may mean they may not understand abstractions, they may have difficulty understanding specific instructions. And you want to know if they read or write, correct? And she has a symptomatic generalized epilepsy. So she has absence, what we used to call petit mal seizures, and generalized tonic-clonic seizures, but she's very well controlled on valproate and ethosuximide when she takes her medicine. She can reasonably manage her medications. We start that process again at 13, but I recommend every adolescent in the United States has a cell phone, so they're much better at turning on alarms than I am, and to reminders, as well as a pill box. I find, and I take medication, so I find pill boxes to be wonderful because I may not remember if I took my medication in the morning or not. But she has difficulty managing money. She can't change money. So you can see where a judge, in judging guardianship, isn't going to take away her right, or he or she will empower her to give assent and participate in medical decisions, but he may give guardianship to the parents for managing money. So there are nuances, and that's where it gets complex. If you have a young adult who is microcephalic, has a small head, spastic quadriparesis, nonverbal, cognitively very impaired, the parents are going to get, or whoever they designate as their care provider will have full guardianship. And she wants to attend college, and that's manageable. In fact, that's where I really find seizure dogs to be really helpful, because oftentimes epilepsy, if you go into a dormitory situation, many of my patients have experienced that their roommates don't want to be with someone who has epilepsy. And that's the stigma of epilepsy that we're all trying to demystify. But a seizure dog is wonderful because they're trained that if their companion has a seizure, they can alert the resident fellow on the dorm floor, for example. Or if they're walking across the street and has a seizure, the dog can alert somebody and stop traffic. So that gives a child, young adult, increased independence. Here's another case, Dravet syndrome. Many of my adult providers have no idea what Dravet syndrome is. Does anybody here? I presume some of you know what Dravet syndrome is. It's a genetic disorder, a channelopathy, sodium channelopathy, that presents usually between 6 to 12 months of age with prolonged seizures, either focal or generalized tonic-clonic seizures in association with high fever. And so often these children initially are designated as having febrile seizures, complex febrile seizures. And their EEGs in between that time in that first year of life are completely normal, and they're completely normal. In fact, in my opinion, they're precocious. But then it becomes a progressive disease because between 1 to 4 years of age, the seizures occur with fever or without fever, although fever and illness are often a trigger. And they undergo a change from having just febrile seizures to multiple different seizure types. Very, very difficult to control. And unfortunately, even with seizure control, there's a progressive psychomotor decline. And it's recognizable. 70% have autistic features or autism, sleep disturbances, in my opinion, close to 100% sleep disturbance, 80 to 90%. 20% have immunologic disorders, which makes them more likely to become ill, and their seizures are exacerbated by fever, excitement, illness. And so I have many patients with Dravet syndrome, but our adult colleagues don't recognize it. And the reason it's so important to make that diagnosis is because drugs like carbamazepine, which is Tegretol, oxcarbazepine, which is Trileptal, lamotrigine, the brand name is Lamictal, and Dilantin, phenytoin, will exacerbate their seizures and put them into status. And our adult providers do not know that. And many of our adult providers inherit these patients who maybe never had the genetic test, so they don't even know that the pediatric provider doesn't know they have Dravet's, and so as a consequence, neither does the adult provider. In this particular case, what made this case even more interesting is the parents insisted on putting them on cannabidiol, which there is some published data on cannabidiol, but this was years ago, where we didn't understand the drug interactions, and there are potent drug interactions between cannabidiol, which is medical marijuana, and these other drugs, felbamate and valproate, not necessarily levetiracetam. And our adult providers at that time said, no way, Jose, we're not doing cannabidiol. So that becomes a challenge. And with this particular family, they were more come see, come saw. Well, the medication doesn't make any difference anyway, so they really didn't comply with any, I felt like I was extraneous. The parents did what they wanted to do, which is okay, but just be honest about it. That helps me. Otherwise, I'll go chasing down a rabbit hole and never quite figure it out. But this would be unusual, that the seizure frequency never changes despite trials of different anti-epileptic medication. That's really, really unusual. Usually we get a change or at least report to me side effects. So that made it more challenging to provide an accurate history to the adult provider. I already went through most of this with you, but just one other caveat is Dravet syndrome is associated with a high risk, I'm not sure if that's working or not, there it is, a high risk of sudden unexpected death with epilepsy. It's one of the few epilepsy syndromes of childhood that has a high risk of what we call SUDEP, sudden unexpected death with epilepsy, 1 in 750. And typically it's much more common in our adolescent and young adult population. So case 3, how many of you know what CDKL5 is? Neither do our adult providers. You do. But I just diagnosed this young girl. She's 23 years old, and the parents, she has history of infantile spasms, and then went on to develop Lennox-Gastaut syndrome, which are tonic seizures, drop seizures, generalized tonic-clonic seizures. And I was able to medically manage her, but the parents really wanted to know what's her underlying diagnosis? Is this going to happen? And she had other organ systems affected, GI in particular. And so she hadn't had genetic testing, neuroimaging, metabolic testing for years. And as you may or may not know, every few months the genetic tests are all different. And our knowledge of the underlying gene mutations, changes in our chromosomes, gene mutations that can cause specific diseases is just explosive. And if you understand what the gene is, you may understand, like we do with Dravet's, that maybe it's a sodium channelopathy or a calcium channelopathy or a potassium channelopathy, which means if you know the underlying mechanisms that's causing the epilepsy and the impairments, we may be able to develop designer drugs that are going to help with the underlying cause of the epilepsy and the cognitive impairments. So to me, underlying the etiology, knowing what the diagnosis is important to me as a provider, and it's really important to the parents. And we were successful in identifying CDKL5, which previously is similar to Rett's, although it's now been separated from Rett syndrome, which means she had autistic features, infantile spasms, most patients like this do, and Lennox-Gastaut syndrome, and she's now virtually seizure-free on felbamate, valproate, and clobazam. She has other significant problems, which means I had to get a lot of other subspecialists together. Osteoporosis required endocrinology, orthopedics because of her multiple contractures. All of the children with CDKL5 have dysphagia and GI dysmotility, so she needs a good adult gastroenterologist who's going to be able to help her. And the single biggest condition that adult neurologists say they don't want to treat is autism. They do not want to treat autism or the behavioral disinhibition and the behavioral issues that accompany autism. So it makes it very complex to transition a patient like this. Case number 4 is a young boy with tuberous sclerosis complex. That's a multi-system disease as well, and it affects the brain. It produces tubers, which I'll show you, in the brain, subependymal giant cell astrocytomas that grow in the brain, hamartomatous lesions in the brain, the eye, the kidney, and multiple other areas. In women, as they approach 30, they develop lung disease with emphysematous changes. So it's a multi-system disease. So you have to round up a number of adult providers who are not only familiar with tuberous sclerosis complex, but willing to engage and help. And in this particular, this is a giant cell astrocytoma. The white patches, the white patches are all tubers in the brain. So it has a high tuber burden. That means it's pretty significantly impaired. Had bad Lennox-Gastaut syndrome, treated with felbamate, valproate, and clobazam, but we ultimately decided to do a corpus callosotomy, and I will tell you, that young boy is virtually seizure-free. He's awake and alert. The mom just couldn't be happier. He's talking now. He's even telling jokes. He loves Spider-Man, so he always does a Spider-Man imitation when he comes to clinic. But he had one of the things with tuberous sclerosis complex is, how many of you have heard of mTOR inhibitors? It affects the mTOR pathway, where we know the tuberous sclerosis genes mutate the mTOR pathway. And if you inhibit the mTOR pathway, you can decrease the size of those hamartomatous lesions and the giant cell astrocytomas and shrink the angiomyolipomas, which are tumors in the kidney. And it also improves seizure control. So again, because we know the underlying genetic mutation, we have been able to develop drugs that affect the specific pathway that causes the cognitive impairments, the hamartomatous lesions in multiple areas, and improves the epilepsy. And last but not least is our patient with Lennox-Gastaut syndrome, which by the time they get transitioned to adulthood, they no longer have the classic seizures that we see in pediatrics. So we have to do due diligence and educate our adult colleagues about, yes, you still use the same medication, and yes, we do know it's Lennox-Gastaut, and don't touch my medication. That's my message that I usually give to the adult providers. But basically, I think I've outlined for you in summary that there's a reluctance of providers, patients, young adults, and their parents to transition. It's a triangle. And there's a lack of adult providers who know these conditions. Adult pediatric providers are unfamiliar with these conditions. They're all, in particular, in areas of large metropolitan areas, there are language and cultural barriers that make it even more challenging. The one who had tuberous sclerosis complex is Hispanic, speaks Spanish only, on medical assistance. Many of our providers don't want medical assistance. And as I'm alluded to, lack of mental health care providers to assist with some of the challenging comorbidities of epilepsy in these conditions. And that can be behavioral disinhibition, aggression, depression, anxiety, suicidal ideation. So we do have some strategies, but I don't want to cut into Simi's time. We will maybe can address this more at the end, but the American Academy of Neurology is full on board to educate the adult providers about these challenges and that it is their responsibility to accept these patients and not say no. So instead of like we say no to drugs, it's going to say, yes, we will accept your patients and become educated about it. And a willingness of pediatric providers to act as a continuous resource. And we keep a list of providers who've said yes, because we don't want to lose them. And then we all have to work on changing our healthcare system, particularly with respect to mental health services. So with that, I'm going to hand it over to Simi. But these are the kids we see every single day. And we'll take some questions at the end, okay?
Thank you, Mary. So I'm a social worker at the Children's Hospital of Philadelphia, and so I'm going to be talking to you about some programs that we found to be effective. Not to say that they're the only place to go for programs, because that's not so. I'm hoping that what we talk about today are things that you can take back to wherever you have your treatments or where you work, or where your children get their services. So to start off with, I would like to just ask Christian if I could do my show and tell. I like to bring props. So one of the props is the information that Mary was talking about from the Child Neurology Foundation. I love these. And I'd like you to really take a look at those, and they're referenced in the slides so you have a way to get those. And then this other book is what we have from the Children's Hospital of Philadelphia, and I'll show you more and talk to you more about them, but you'll also see that we have materials that are what we call patient-facing, because we have a community health worker that has created these, and we've had young adults and patients of ours look at them to see if they would work for them. So we'll talk more about that in a minute, but you could just get those started. So I like to talk about this as the transition dance, and it's where young people have to start taking responsibility, because most of their time they have their parents telling them what to do, or their healthcare providers telling them what to do, and then the youth has to begin to step up. And so I think about them stepping up. I actually like them to step up before 18. My preference is to step up around 14. That they start looking towards independence, living on their own, and becoming employed, and that they take charge of their lives as they should. And what we find is that their health care is not as important to them as it is to us in health care. So important for us to think about it. So when I think about the path to transition, I remember my first grade teacher, and she used to put us in 3 different groups. And the first group was getting ready, and that meant the ones that really talked too much in class. And then on your way were the ones that are, you're pretty good, but you're not great yet. And oh, we are there. It was like, you're really there. And so I was reminded about that as I started down my own road of working with transition to adulthood, which really began when my son was 6 foot tall and off in his first year of college with a chronic illness, and coming home at Thanksgiving and ending up at the Children's Hospital of Philadelphia emergency room, where his feet were over the top of the gurney that he was on, and realized that he was really a little bit too old to be there. And so I remember them asking questions like, what did you do at college, and were you drinking, were you smoking, and lots of things that as a mother I really didn't want to know about, but we needed to figure out if that's what landed him in the hospital. And then when they went to I remember asking for him to be seen by the IV team because they were going to admit him because they couldn't figure out how to get him hydrated because he was so big. And the IV team came and he got hydrated, and we had to wait in the waiting area where there were only cartoons on, and then it became obvious that he and I both needed to go to another place, and we ended up, fortunately, the University of Pennsylvania Hospital is nearby. Fortunately, I had friends that knew some adult providers, and we were able to get his care transferred. But it was a process of getting ready and being on your way, and finally getting there. And so one of the things that I like to just say is that at Children's Hospital of Philadelphia, we have a way to put together the healthcare piece, the education piece, as well as the relationship piece. And I find that the Child Neurology Foundation, who sponsored us for our talk today, as well as the other sponsors, really go along very much with that whole philosophy of pulling together not just the healthcare piece, but the psychosocial and educational pieces as well. So one of the programs that we created back in 2002 is a program called REACH, Rapport Empowerment Advocacy Through Connections in Health. And just like the Child Neurology Foundation Transition Project that Mary and I are on, we have individuals with neurological conditions, their parents as well. So we're informed by people who we're talking about. So we're following the nothing about me without me thinking. I had gotten a grant from the Pennsylvania Academy of Pediatrics and the American Academy of Pediatrics, and we took a look at what do we need to do to create programming for young adults with rare disorders like we see here at this conference. And with that funding, we were able to do focus groups with parents, with kids of different ages, with pediatric providers and adult providers. And my young adults that I spoke with who are already in college and already had transferred their care to adult providers met with me, and it was on Martin Luther King Day because everybody was off from school that day, and they came up with the title, REACH, and I said to them, well, now that we've created this, now that you've talked to me about it, you have to help me do this. And so that started, REACH started in 2002. Our kickoff event was in 2003, and I challenge anybody in the room to think about doing something like this wherever you live to be able to get the voice of youth into the mix of deciding what they need to be able to be successful with transition. Oops. Okay. So it's a program that was created by teens for teens. And our mission was to prepare teens and young adults with special healthcare needs for a successful transition into adulthood by providing peer support, guidance, and resources. And we had a vision, and this was our vision, and that was to locate and help to develop and establish adult healthcare as well as services that were available in the community, educationally and vocationally. I'm proud to say that was our vision in 2003, and we're absolutely doing that now. And everybody needs to strive for this. This also goes along with our federal government, with our Healthy People 2010. We're now into Healthy People 2020, so it was always helpful to know that we're in collaboration with and aligned with what we're hoping to happen in our country. So we've had REACH workshops for a number of years, and this was one of the first ones. You can see that it has, we're talking about self-care, and we want you to start with, we want youth to start with self-care as early as they possibly can. You think about the 4-year-old that has to know that they have a peanut allergy if they're going to the friend's house and what they can and they can't do. The materials that are coming around from the Children's Hospital of Philadelphia, we have brochures that start at age 4 to 7. It's like 4 to 7 for parents to help kids begin to start owning their own diagnosis and their own needs. Self-advocacy as early as possible to be able to say, this is what I have, this is what I need, this is how I can stay safe, this is how I can stay healthy. Thinking about how they can coordinate their care, and really, to try to help make sure that the doctors know what are happening with them, that they share information with each other. And I think about having a one-page medical summary, which is one of the things that we talk about and that Mary also spoke about. And I was wondering, any of you that have medical conditions in the room, how many of you have a one-page medical summary with you right this minute? Am I the only person in the room? Oh, I see a hand. I see 2 hands. I see 3, okay. So just remember that. Nobody's going to know what you need unless you have it really available, and it's something that we teach our young people about. We talk about just wellness, overall wellness. You see them being on a therapy ball. We try to do fun things, try to do yoga and other kinds of things to help take care of yourself. And then, how they can have healthy relationships and understand about sexual health and taking, making sure that they know that if they take any kinds of medications, how that interfaces with whether it's birth control or whether it's drugs or alcohol. And then we want to make sure that they know what they're eligible for. One of the things that really irks me as a social worker is having to make sure that the youth know what they're eligible for, that their parents know what they're eligible for, and they get everything they're eligible for. When they're under 18 and under in the United States, we have the IEP, and we have a 504 plan, and we have what people are entitled to. But once you turn 18, those entitlements go away. And if you don't know what you're eligible for, you don't necessarily get them. So I want to make a plea that you find out in your state what your state provides and how you make sure that you get what you need. And that you advocate for getting those services, and you find ways to have, people usually can help each other. And with a lot of you, you're parts of, I'm happen to be the social worker in the Trisomy 21 program at CHOP, and we have a very strong group of, groups around the city and around the state for Trisomy 21, and the parents help each other, the kids help each other, and they know they're very current in how to get all the best services, the best recreational services, and so forth. And then also making sure that you get all the pre-vocational planning. I mean, the one thing that one of my mentors, Patience White, who does a lot of work in transition to adulthood, she's pediatrically and adult trained, talks about that transition starts at the point of diagnosis. Well, when you have, when it's a genetic disorder, it starts at the point of birth. So at the point of birth, when you may maybe find out later, but how do you find out what it is that you're going to need, as well as how long you're going to be working with the different professionals that you're working with. Sometimes there are a number of conditions where it's a capacity issue. So people might have to move on to adult health care because they're just in a pediatric hospital, and they need to find adult health care providers because the new young children with that diagnosis are coming in, and so we need to make sure that there's room. And so one of the things that we do have at the hospital is a new program. This program is in its 3rd year. We just went from being a granted program to being a program that's part of the hospital, and that is a MINT program, Multidisciplinary Intervention Navigation Team. And we have, you can see there's an evidence to action brief that if you have the opportunity, you could look that up and might be able to get that. You'll get to see some of the things that's really great about, I'm just going to back to our team, is that I'm the social worker on the team. We have med-peds providers. That means they're people who are trained in both pediatrics and adult medicine. We have an adult nurse practitioner who really understands what the needs are of adults, and he is consulted. They call him in when people come in that are adults in the children's hospital to make sure they're getting the right level of care. But what we do have is a lot of our physicians say pretty clearly to us, I was trained in pediatrics. I was not trained in adult medicine, and we feel very strongly that adult doctors really need to take care of adult bodies. And so even though people are bonded to their physicians, there's a question about how does that work, and how do you make sure that your physician can be on top of all the things that you have. Having said that, I feel a little disingenuous because I'm also part of the Trisomy 21 adult program at CHOP. And the way that works is Dr. Mary Pippin has been doing Trisomy 21 Down syndrome for, I don't know, probably 35 years, and is really an expert. She's is called to speak in many different places, and she does see people in the adult clinic. I actually go to the adult clinic myself with her, and we have a nurse practitioner who happens to have a child with with Down syndrome. We have a coordinator who has a child with Down syndrome, or a PT has a child with Down syndrome. I have a family member, a close family member with Down syndrome as well. And we are at the clinic, and in that clinic, we just look at the issues around Down syndrome. So if they need anything else, and I know that Mary had talked about some patients with complicated medical needs, I made them promise, because I do transition at CHOP, that everything else gets done outside of CHOP and gets done in the adult world, because they have adult bodies. The MINT program also has, besides social work, we also have a community health worker. And what's really awesome about that, her name is Katie. Katie has a chronic illness, grew up with a chronic illness. She transferred her care from Children's Hospital Philadelphia to Penn Medicine, which is next door. And she is really great at talking to the young adults. They don't really like listening to me. They certainly don't like listening to their parents, but they do listen to Katie. Because Katie talks to them either in person or by phone and says, I hated having to call and make appointments for myself, but here's how to do it. So the information from CHOP that's going around, she's developed some scripts for kiddos. She sits with people and helps them make those appointments. She really helps them understand why they have to take responsibility for themselves. And so when we do our REACH events, one of the things I forgot to mention is that we have a mentorship program. She heads up that mentorship program. We have mentors with different chronic illnesses, unless we're doing a specific conference. So if we do a REACH program for neurofibromatosis, for example, our mentors have neurofibromatosis. When we do a REACH program for sickle cell, our mentors have sickle cell disease. So we do try to match people up in that way, and it gives people an opportunity to say, this is what happens to me with my diagnosis. And then we have some generic ones, like we have REACH for college. It doesn't matter what your diagnosis is, but we bring people together. And the last thing that I wanted to talk about before I get into the child neurology materials, and I was charged with talking to you about employment. And employment's hard. It's hard for all of us, but again, going back to the whole idea of transition beginning at the point of diagnosis, starting to do chores early and often, being responsible to do volunteer work, being responsible to the greatest degree that you can. We know that some individuals need actual hand over hand to be able to contribute and give out flyers or do things that are meaningful. And other people really have lots of other opportunities. And I find in my program that we're going to be talking about, which is called CHOP Career Path, in that program, I find that parents don't always expect their kids to know what they can do or to be able to do what they really are capable of doing. And so it's really critical that we have opportunities for youth to do all that they can do. For the youth that are in the room, how many of you feel as though your parents really know how much you know how to do? Yeah, one. Okay, that's good. Because sometimes what happens is that I'll have parents, they'll say, my son or daughter can't take their medication themselves. My son or daughter would never be able to get a job at the Children's Hospital of Philadelphia. Our program has hired more than 50 people with different chronic illnesses and disabilities. We've also heard from youth with our Reach for Epilepsy event. We had a youth in the room with Dr. Larry Brown, from a colleague of ours, a neurologist, and the youth said, you know what, my parents don't think I know how to take care of myself. But when I'm at a friend's house, I always take my medicine. But I'm at home, I don't have to remember, because my mom will always remind me. And so then he came into the parent room. I tend to get the parents, and came into the parent room, and I'm with the parents. And there's one parent who said, I am so afraid that my son, who has epilepsy, is not going to take his medicine, and he's going to die. And so that's really scary. And I was sitting there, oh my goodness, how come he doesn't know, and whatever. Well, she says this, in comes Dr. Brown. He says, you know, this funny thing happened up in the kid room. And the mother was sitting in the back. She says, I bet I know who that was that said that. And it was probably the same kiddo who basically just lets his mom do it for him when he's at home. And so I want to just all of you, parents, I want you to have expectations and find out what your kid really can do. And for the youth in the room, you really need to speak up and say, this is what I know how to do, this is what I can do. So anyway, we have these programs the program that I have does do a lot with personal development, does a lot with setting skills up and teaching different skills, like how to have positive engagement over the phone, or how to do an email, or how to really understand what the person can do. And we have a number of internships. Here are some of our young people who are working at the hospital. Charles, who is on the upper right-hand side, he's going to celebrate 10 years in November. I'm very proud of him. He now, with our CHOP Career Path program, which proactively evaluates youth to find out what they're capable of, it's paid for by our Office of Vocational Rehabilitation in Pennsylvania or the Division of Vocational Rehabilitation in New Jersey. We do evaluations. We look for individuals' gifts and abilities. And Charles actually does help with orienting our interns that we have, and has taught them how to do some of the work that he does. He does SOS runs. He has a motorized chair. He happens to have cerebral palsy. He can get things to the floors quicker than anybody else. And he's, sometimes thought of as the mayor of the hospital. So we've had some success. We've gotten some recognition. I wanted to speak a little bit quickly about the national resources. I don't know whether you've looked into this, but many states, in the United States anyway, have employment first states, and you can look on the website that's listed there, the Association of People Supporting Employment First. Pennsylvania is an employment first state, so is New Jersey. What that means is that they're starting to put money into making sure that everybody works. That means everybody works, regardless of how involved a person could be. I love the Job Accommodation Network website. It's www.askjan.org. What I love about it is it talks about, like, whatever your challenges are. If you have trouble with your hands, like you don't have strength in your hands, what are reasonable accommodations? And I tell people to look at that for whether they're going to school and want to get it into their IEP, or they're going to work. I've done some work with the Frederick's Ataxia group at CHOP. And people come from around the world to that program, and by showing them the JAN website, they get to see what they can talk to their employers about, especially when they start losing function and they have to go in and discuss some of their other needs. I put Project Search up there. Many of you are probably from states or around the world. They have places in England. They have someplace in Ireland. I met somebody from Ireland here. They have programs in Australia. It started at Cincinnati Children's Hospital in 1996. They really gave us really good ideas of how to develop our program. And so you may want to find out if there's a Project Search in your area, if you have a disability and you need special assistance. There's also Centers for Independent Living all over the United States. And then there's one website that I think has tons and tons of information, and that's this Go Transition. I didn't put the URL because all you have to do is type in Got Transition. And there's a transition readiness assessment questionnaire, which is similar to some of the child neurology materials. And so the child neurology materials are available to you. They've been sent around the room. They really do help support families and youth to really develop the one-page summary, to develop some care needs. They have the principles that Mary talked about. I particularly love the self-care assessment. So as a youth or as a parent, depending on whether the youth can do it themselves, my preference is always to have the youth do it themselves, is to say what they can do or what they need help with or what they need to learn. And then on the side of the parent, if you're afraid your child can't do it, why don't you find out? And whenever we have our REACH events, we basically use something like this. We actually use the Transition Readiness Assessment Questionnaire, and we give those out to parents and kids night one, and then we have them compare notes to see if they agree or disagree. And night two, they have to come back and say, what did they talk about, and what did the parents find out that the kiddos could do that they didn't know they could do. And so then there's the comic book that went around, and if you go back to the Child Neurology Foundation table, there are extra copies. It's really a great way to connect with kids about neurology and those issues. And here's the website where you can get all the information and other materials from the Child Neurology Foundation. And we're ready for questions.
Are there other assessment programs like the one you were describing at CHOP across the country? And if so, what children's hospitals are they available at that you know of?
We have one available at Children's Hospital of Orange County, Cincinnati, certainly CHOP. Do you know? There are probably many others, but they're in various stages of maturity.
So it depends. Also, one of the things that I would suggest is if you're talking about somebody who's still in school, is to make sure that that person that's still in school gets a functional assessment before they leave school, or they get a neuropsychological testing, which really goes into a lot of different details. Our program has we have physical therapy, occupational therapy, speech therapy, social work, a job coach who used to be a special ed teacher in autism, and a vocational coordinator. So we're really blessed with being able to put together a team, but we were able to get the Office of Vocational Rehabilitation to pay for that. And so we're on site, everybody is on site, they all work for CHOP, and then when the individuals come in for their evaluation, they get CHOP badges and come in as non-traditional personnel, so that they get to learn all the different things that are happening in the hospital. So they also have to prove that they don't have a history of abuse or any kind of violence or anything like that. But so I don't know exactly where those places are, but there are a number. A lot of programs that are work-related programs tend to not do as much of evaluation as we do, but we found that people weren't ready to go right into jobs without the evaluation. And our youth do work trials for 3 to 6 months, sometimes 9 months, before they get employed. When they're work ready, we try to get them a job, and then hopefully a CHOP, but we do have people, believe it or not, that don't want to work a CHOP, and we get them jobs in the community.
And in the state of California, those who are on medical assistance, CCS in particular, between 18, they do a transition from high school to adulthood between the ages of 18 to 22, where they're transitional programs where they actually have, we evaluate them with neuropsych evaluations because we have a multidisciplinary team as well, with a social worker, thank God, and a neuropsychologist, psychologist, dietitian, pharmacist, nurse practitioner, and physician, who we try to do a comprehensive evaluation. Regional centers in California will do evaluations, as will the counties have different job evaluation programs. But if we can provide additional information, because Simi's right, the neuropsychological testing that we do and you do provides additional information that you won't get in the testing. And then we find that high schools vary, counties vary, unfortunately, but some do an excellent job of really transitioning our young adults, 18 to 22, into work placement, and they'll test them for like 3 to 6 months and find them an employment job. And the places that are really good are places like Albertsons, Walmart, and what's the barbecue place? Famous Dave's. Famous Dave, I know his nephew, and I have worked, that originated in Wisconsin, and I'm from Wisconsin. And he makes it a point to, half of his employees are young adults with special needs. And he's really dedicated to doing it, so you can find little niches in different places in your community.
So I just want to challenge your thinking, and that is, think of every single person that you know and what jobs do they have, and what would they be open to hiring anybody that has any special needs. That's what I do when I go to parties, right? I find out who you are, and What do you do? And have you hired anybody with a disability? Because have I got somebody for you? And so at CHOP, our youth, what we do is we find out what their strengths and their gifts are, and then we look for a place for them to do their internships. And then if they do great at their internships, sometimes what we have to say to the people, the staff that we're working with is try it before you buy it. If they do well, you'll hire them. If they don't do well, then we'll move them on to someplace else. And we've had people in an internship for 2 weeks, and we just said, done, we can't do this. And we've had people in internships for 3-6 months, and one of my favorites is that she was ready, she was work ready, and we said, come on, we need to get you out of this place because they're not hiring you. And she says, no, I like it. And she had intellectual disability. She was very comfortable there. They ended up having a part-time job opening in a little bit. She applied for it. They asked her, well, why do you want to work here? She says, I love CHOP. I love what I'm doing. She got the job over other people because other people just wanted to get their foot in the door. And she just was very happy with it, and she's been there 8 years. So, and she actually works in the GI department, and as she has done better, she's done more things. We have somebody with autism who actually felt more comfortable in the linen department. I'm not thrilled with the fact that she went to linens, but that's what she wanted to do. I really wanted her upstairs, not downstairs. But she did the linen department, and she started doing so well that they started bumping her up. They said she has autism, just a lovely, beautiful young woman. And they said, well, we would like you to start training other people. We'd like you to start doing other things. We want you to move up. And so what has happened is people's gifts have been able to be realized because we've given them those opportunities. But if you don't have it, ask for it. I mean, there's the Project Search model, there's the model we have, there are models other places.
We do have one question from online regarding transition to the workforce. If the disorder isn't obvious but will require numerous doctor's visits and potentially time off for treatments, do you recommend making the disorder known to the potential employers in advance?
Well, the person really has to get the job first, right? So I think that we counsel our young people. It depends. I mean, if they're in our program, it's obvious that they're there for a reason. But we do want the person's merits to be looked at first in terms of what their abilities are. As it gets either closer to the job being offered or the job is offered, then we do want them to disclose early on, because it is usually most places get federal funding and they have to make reasonable accommodations, and so we counsel them about how to discuss their what their needs are so that they can say, I'm going to be needing time off. What's happened, though, that's been interesting, is that some of the kiddos that have come into our work program have found a way to make all those doctor's appointments happen that it doesn't interfere with their workplace. Or they say, I'm going to need 2 days off a month because I need to take care of these things. And so that's really important. What does get people in trouble is if they don't tell us what they have, or they don't ask for the time off, or they don't call in when they're sick. So, I mean, that'll get somebody fired, and we agree with that. If we teach them that they need to be open and honest. We also, I forgot to mention, we also ask that they work with their disability services offices at their colleges so that they can also get, you can't go into your finals and say, by the way, I have this condition and I feel sick and I can't take my test tomorrow. You have to really go in the beginning after you've gotten up into the college and you talk about what you need. And we also counsel them to ask what kind of disability services they have there.
Many of them don't. Yeah, many of the young adults don't want to acknowledge that they have any challenges at all. And that's what gets them into trouble, because they'll go to college and they haven't checked in with the college program to see what tutoring may be available or accommodations for test taking, or sometimes they'll have a seizure in the morning and they may not be able to make it to class. And that's what gets them into trouble. So we really work with the colleges, and for the most part, the colleges have been very accommodating.
Yep.
You had a question?
Hi, I'm Katie Stevens with Dyskeratosis Congenita. I commend you for what you're doing. I work closely with Dr. Tim Olson at CHOP, and so I do know about your program. It's interesting, though, because I work with, we have a world-renowned medical advisory board who just brought up the topic of teen to adult transition, because really, for the first time ever, our patients are living into adulthood, and so finding and I may have missed this, I'm sorry, I had to step out for a phone call, but for the first time ever, our patients are living into adulthood, and so we're finding a huge gap getting them into care with an adult, because I agree with you, an adult, doctor should see an adult patient, but we have a huge gap. And we actually lost a patient last week who was in need of, palliative care, but nobody understood the disease and why mom was making the choices she was making with DNR and that sort of thing. So what do you recommend? We're so spread out across the nation. What are some resources that we can look into to bridge that gap?
That is a challenge, and that was in part why the transition task force was put together for children, young adults with neurological conditions. I can say that the American Academy of Neurology is fully committed to educating adult neurologists that it's not only their responsibility, it's their duty. They took the Hippocratic Oath. They have to get on board with our pediatric providers, because pediatric neurologists are quite rare. In fact, there are only 1,400 of us, and 50% of us are over 50, including myself. And we're not going to go on ad infinitum, and we're not training enough for the 4 million consults that we get a year. So Simi talked about capacity. That's a real issue for us. And so I think it is the other practitioners that I found, because many places are rural, not necessarily in metropolitan areas. I found the American Academy of Family Practitioners and nurse practitioners very willing and really understand the concept of the medical home, and found them very willing to educate themselves about the condition and work, as long as they have the resource, as long as we provide them with our phone number and how to get in touch with our office in case they get into trouble. I found that transition to work out nicely. But it's a work in progress.
Yeah, I mean, the article that Mary referenced in the beginning and the evidence to action article that I referenced are good starting points for people to take a look at. Otherwise, you should just have a MINT team like we have at CHOP. And we're happy to tell you all about it.
Yeah.
And you can refer, CHOP patients should be coming to that program.
So I'm actually a CHOP patient, and I have chronic illnesses that, like, I have a central line, a feeding tube, but I went through, I just graduated college. With accommodations, I was able to, it was actually easier than high school. I could schedule my appointments around my classes, and currently doing my master's, so I have a little flexibility with work right now, but I'm ending that point of my life where I have that flexibility that I become kind of accustomed to be able to deal, and I'm like feeling very overwhelmed about applying for jobs with all the medical devices. What do I go in? What do I hide? Like, I generally hide my port when I'm going in for interviews, but what happens if I have to call out suddenly? How much tolerance is my employer gonna have? And there's so many issues with chronic illnesses, and going from college to the workforce, and I'm going into teaching, which probably makes it worse. It's a challenge because I can't just take off 2 days a week of work, 2 days a month of work. Like, that wouldn't work for me. So trying to coordinate my care and what I disclose, I don't know where to go with that. So is there any programs out there to help more like the chronic illness side?
Are you still in Philadelphia?
I'm still in Philadelphia. I'm still at Temple. I still actually see a couple people at CHOP.
I'll give you my card at the end.
In general, though, employers, if you're hired by an organization that has over 50 employees, there is a federal medical Family Medical Leave Act that actually protects your job, and you won't get paid on the days that you miss. But even as a teacher, if you were to miss 2 days out of the month, I didn't know if it was 2 days out of the week or 2 days out of the month. It really is, the American for Disabilities Act and the Family Medical Leave Act is really there for the protection of, because all of us can have medical challenges, and you shouldn't have to feel like your job's in jeopardy. And that's where I would presume there at CHOC we have counselors who can, and the regional center, who could work with you, and I'm sure other states have that
Yeah.
as well.
There's also the 503 of the Rehabilitation Act, and what that does is anybody who, again, if you have over 50 employees, you're supposed to have a certain number of employees, 7% of your employee group should have disabilities. It was something that Obama put into place. And so if people are really following what the Rehab Act says, they would count you as somebody that falls into that category, which is a good thing because they get it's a civil rights violation if they don't hire people with disabilities.
So I was a CHOP patient as well, and my question is more involving the transition to being an adult patient. And are the pediatricians, are they involved and are they helping in that process? Because I was told that I could stay at CHOP and then all of a sudden at 20 it was off to UPenn. And also, in my experience, the doctors weren't really partners when I was younger. They were more, this is the way it's done.
So there have been a lot of changes. And, physicians are doing a lot more in partnership with patients and with families than they may have done when you were younger. And in terms of, has every single doctor at CHOP, are they ready to help people transfer to adult care? The answer would be no. But we do have some patients that part of their care stays at CHOP because they are so complicated, but whatever is safe for them to transfer to adult care, that's what we want them to do.
And the American Academy of Pediatrics was fully on board with this task force. So they're actually one of the biggest proponents of transition and working with the Child Neurology Foundation, the American Academy of Neurology, the American Academy of Family Practitioners. So it is a complicated system, in part because of our current healthcare system and the way medical assistance reimburses, number one, and pediatricians are very busy. It's a volume-based business, and I hate to use that word because I never went into medicine to be in business, but many of the pediatricians do defer to child neurologists and don't want to take care of the basic pediatric needs of some of our children and youth with complex medical conditions. And so we become de facto the primary care provider, and we're working very hard with the American Academy of Peds to change that, because the American Academy of Peds has endorsed the concept of a medical home, which means the pediatrician should be actively involved. But that is a process. It's not perfect right now by any stretch of the imagination, but we are working very closely with the AAP.
So we've run over a little bit on time, and this is our last track here. So if you have another session you want to go off to, you're more than welcome. Otherwise, I can leave it open if you guys would like to answer a couple more questions. That's okay. Anybody else have questions? Oh, well, that worked out perfect then. Well, don't forget to take the survey in the app of the session, and I hope you guys enjoyed. And can we get another round of applause for the speakers?